Hello and welcome to a CPD update presentation from the Rehab Psychiatry Interest Group in Scotland. Today we are going to look at reducing the cardiometabolic risk in patients with severe mental illness. This is increasingly overtaking extrapyramidal side effects as the primary concern following the rise in second generation prescribing. In general, someone with a BMI over 25 kilograms per metre squared is classed overweight and over 30 obese. A waist circumference of 94 centimetres or 37 inches in men or 80 centimetres 31.5 inches in women carries a higher risk of coronary heart disease and metabolic syndrome. Weight gain increases the risk of dyslipidemias, hypertension, metabolic syndrome, type 2 diabetes, as well as coronary heart disease, osteoarthritis, and some forms of cancer. The prevalence of diabetes and obesity is twice as high in patients with schizophrenia. The reasons for increased rates of weight gain in schizophrenia are multifactorial and include genetic factors, lifestyle factors, and treatment-related factors. Now, before we go any further, let's review some basic metabolic endocrinology. Glucose, galactose and fructose are the principal monosaccharides. They are 6-carbon sugars which are metabolically interconvertible. Oligosaccharides, such as sucrose, contain 2 or more monosaccharides. Carbohydrates are digested in the intestine to form monosaccharides which enter the liver via the portal vein. Galactose and fructose are converted to glucose in the liver. Excess glucose is stored in the liver as glycogen in a process called glycogenesis. Glycogen can be converted back to glucose through glycogenolysis. Glucose can also be converted from amino acids in a process called glucogenesis. Glycerol, from the breakdown of triglycerides, can also produce glucose. Lactate, formed in anaerobic glycolysis, is also converted to glucose. In a fasting state, the liver maintains a constant blood sugar level. In muscle, glucose is phosphorylated to glucose 6P. Glucose 6P is either converted to glycogen or oxidized to pyruvate in a process called glycolysis. To generate ATP in the absence of oxygen, pyruvate is converted to lactate in anaerobic glycolysis. Now let's look at aerobic glycolysis. Pyruvate is transported into the mitochondria and loses carbon dioxide to form acetyl-CoA, a 2-carbon molecule. When acetyl-CoA is oxidized to carbon dioxide in the Krebs cycle, chemical energy is released and captured in the form of adenosine triphosphate. Now, let's look at the pancreas. The pancreas has both exocrine and endocrine functions. Exocrine functions involve the production of enzymes involved in digestion, such as amylase, protease, and lipase. The islets of Langerhans contain endocrine hormone-producing cells. Alpha cells produce glucagon, beta cells produce insulin and amylin, delta cells produce somatostatin, gamma cells produce pancreatic polypeptide, and epsilon cells produce ghrelin. A large number of G-protein coupled receptors regulate the secretion of insulin, glucagon, and somatostatin. Members of the glucagon receptor family, such as glucagon-like receptor 1 and gastric inhibitory polypeptide receptor, promote insulin synthesis and secretion and help control appetite. Insulin consists of two polypeptide chains, the alpha and beta chains, linked together by disulfide bonds. Insulin regulates the metabolism of carbohydrates and fats by promoting the absorption of glucose from the blood to skeletal muscles and fat tissue, and by causing fat to be stored rather than used for energy. Insulin also increases glycogenesis, inhibits glucose production, increases lipid synthesis and fat storage, and also increases cellular potassium uptake. Glucagon increases serum glucose by promoting glucose production or gluconeogenesis and glycogen breakdown, glycolysis. In diabetes type 1, beta cells are selectively destroyed by an autoimmune process, leading to an absolute lack of insulin. Type 2 diabetes is a metabolic disorder with hyperglycemia being caused by insulin resistance and a relative lack of insulin. The proportion of insulin resistance and beta cell dysfunction varies in individuals. The long-term complications of diabetes include heart disease, stroke, retinopathy, nephropathy, peripheral vascular disease, neuropathy, and risk of thrombosis. A random glucose of more than 11 millimoles per litre or a fasting glucose of more than 7 millimoles per litre indicates a high risk of diabetes. Glycolated hemoglobin, or HbA1c, should typically be less than 6% or 42 millimoles per mole in non-diabetic patients. HbA1c levels can vary considerably in diabetes. Metabolic disorder is diagnosed with three of the following symptoms: central obesity, hyperglycemia, hypertension, decreased low-density lipoproteins, and increased serum triglycerides. Lipoproteins consist of both lipids and proteins and help transfer fats through the bloodstream. The fats carried are cholesterol, phospholipids, and triglycerides, and the amounts of each vary considerably. Increasing the concentration of low-density lipoprotein particles is strongly associated with increasing the risk of arteriosclerosis within the walls of arteries. Increasing concentrations of high-density lipoprotein particles decreases the accumulation of atherosclerosis. The recommended level of LDL should be 3 millimoles per litre or less for healthy adults, or 2 millimoles per litre for those at high risk. An ideal level of HDL is above 1 millimole per litre. Recommended total cholesterol levels should be 5 millimoles per litre or less for healthy adults, or 4 millimoles per litre or less for those at risk. The ratio of total cholesterol to HDL should generally be below 4, as higher ratios increase the risk of heart disease. Ideally, triglycerides should be less than 1.7 millimoles per litre. Systolic blood pressure should be less than 140 millimeters of mercury and diastolic less than 90.